السلام عليكم دكتور هاب. احنا ممكن
عليكم
نبتدي كده
السلام.
كمان.
ممكن نبتدي.
يا دكتور اتفضل.
Okay, you see my screen now.
واضحة يا دكتور.
Okay.
شايفين.
Bismillah ar-Rahman ar-Rahim. Today we are going to continue our case-based discussions based on MCQs, visual diagnosis, and case of index of suspicion. And the goal is to train ourselves on how to do smart clinical thinking, smart approach to differential diagnosis, how to narrow the differential diagnosis to reach an actual diagnosis based on history, physical exam, laboratory findings. And my advice to you, if you are using Google or AI, you will not gain any benefit from this lecture. So please try to communicate with us, use your own knowledge. And if you have any comment or questions, please wait till the end of each case, and then we can discuss your comments and questions. Okay. We'll go with the first one. The first one. Okay. This is a healthy 3-week-old neonate delivered at term. And the problem is progressive poor feeding, weak cry, unusual eye movements, and significant head lag. So this baby was healthy, was born healthy, and at the age of 3 weeks, started to develop manifestations of weakness and hypotonia. We can have a baby who has only weakness, which is diminished spontaneous movement or movement resisting opposition, or a baby who has hypotonia, and the tone is the initial internal tension of the muscle or the muscle response to passive resistance. Or you can have both. The baby can have both hypotonia and weakness, and this is in most of the cases. But they are two different categories. They are two different symptoms and signs. This baby has both. He has
دكتور إيهاب احنا كده مش شايفين الشاشة والصوت.
something wrong happened.
اه
We are back again. Now you see the screen
تمام.
now.
كده تمام يا دكتور.
So this baby has both muscle weakness in the form of poor feeding, weak cry, as also head lag, significant head lag, which means hypotonia, and there is unusual eye movements, which means abnormal cranial nerves. This is the interpretation of these key words. So when you have a baby who has been healthy at delivery and for 3 weeks and then develops progressive illness in the form of weakness and hypotonia, and it is progressive. So what is your differential to start with? Give me your differential to start with, and we'll try to narrow the differential as much as we can. رجاء من حضراتكم الأسئلة تبقى في خانة Q&A. خانة Q&A. Where is this? Oh yeah, Q&A. Okay. When we talk differential diagnosis, we have to talk broadly, meaning where is the lesion? What is the lesion? For hypotonia and weakness, it could be either central, affecting the brain, globally affecting the brain among other problems. It could be an upper motor neuron lesion starting from the motor cortex till low down in the spinal cord, where the peripheral problem starts from the anterior horn cell, peripheral nerves, myoneural junction, and muscles. So it's either central, upper motor neuron lesion, lower motor neuron lesion. Don't jump into diagnosis because somebody wrote it might be SMA. We don't think this way. We are not jumping into a disease now. We are jumping into disease category. So we'll try to know if this is an acquired problem or it is congenital problem. And if it is whatever, this is the, what is the lesion? But where is the lesion? Is it central, upper motor neuron lesion, or peripheral nerve, myoneural junction, or muscle? What do you think? Is this a central hypotonia with weakness, or it's a peripheral hypotonia? Okay. Did you hear my question? Okay, it is central. Okay, why you think it's central hypotonia? Asma Gamal, why you think it's central? And you think it's no, central is different from upper motor neuron. You should select one of them. You have central global hypotonia associated with other illness, upper motor neuron lesion, or peripheral, which is anterior horn cell, peripheral nerve, myoneural junction, or muscle. So cranial nerve affection. What does this mean? What is this diagnosis? Cranial nerve affection. Cranial nerve affection. This baby has significant head lag, weak cry, poor feeding. Why do you think it's only cranial? Abnormal eye movement. What is this diagnosis? This is not a category of disease. Okay. I will proceed. Okay. So most probably this is an acquired problem because the baby was healthy till the age of 3 weeks. And then he started to develop combination of hypotonia and weakness. There is no other evidence of other problems like sepsis. There is no rash. There is no, whatever is not mentioned in the vignette is not there. So we are going to use the information that was given to us. They didn't mention there is a fever, there is a rash, there is organomegaly, there is maternal history of HSV or sepsis or chorioamnionitis. So we are ruling most of the the central. Is it chromosomal or abnormalities like trisomy? Is it genetic problems like Prader-Willi, which causes central hypotonia? No. Why? Because this baby was born normal, healthy. So we are left with upper motor neuron lesion or peripheral, which is peripheral nerve, minor junction, or muscle. So what do you think? Is this an upper motor neuron lesion which will develop out of the blue? It can happen, but we don't have an evidence of like stroke, intracranial hemorrhage, thrombosis, seizures, apneas. We don't think it's an upper motor neuron lesion. So it's either peripheral nerve, myoneural junction, or muscle. So we are trying to limit our differential now. Is it a muscle disease? Is it a myoneural junction, anterior horn cell? Usually with the anterior horn cell, you have what they call muscle fasciculations, which is not the case, as in SMA. So this is either peripheral nerve, peripheral neuropathy, myoneural junction, or muscle disease. So another important issue or keyword, the family has recently moved to a new housing development. New housing development means there is a lot of sand, there is a lot of rubble, there is a lot of possible contaminations because it is still under construction. This could be a keyword. They did urgent intubation, admitted the baby to the intensive care unit, and the treatment was started immediately. Question is, of the following, the most likely outcome for this neonate is, so to know the answer, you should know what problem this baby is having. What problem this baby is having. So this baby is going to die in the first year of life. Will have full recovery once he receives supportive treatment. Progressive neurological deterioration. We'll go into CP, for example. Static neurological function. We'll have a neurologic deficit, and that's it. Okay. Let me try to give you some hints before we go into the diagnosis. Okay. This is okay. These are the characteristics of central hypotonia, and you can see if it's related to this baby or not. The tone is reduced to relatively more than in his muscle strength. Okay, this could be the case in this baby. Hypotonia is typically mild to moderate. This baby has massive head lag, which means it is a massive hypotonia. It is mild, not moderate, not mild. So this is against. Limbs typically retain anti-gravity power. We don't know about that. There may be some head lag. There was no head lag whatsoever in this baby. Deep tendon reflexes are present, maybe depressed or increased. We don't know about that. Positive Babinski, they didn't mention that. Persistent neonatal reflexes, they didn't mention that. So the only characteristic that is against central hypotonia is that the hypotonia is massive and the head lag is massive. For peripheral hypotonia, it's characterized by weakness is the most significant finding. So this baby presentation was mostly weakness. In addition to hypotonia, in addition to cranial nerve involvement. Absent of or extremely reduced anti-gravity movement. Didn't mention about that. Significant head lag, yes, yes, yes. So absent deep tendon, we don't know about that. Negative Babinski, we don't know about that. Absent neonatal reflexes, they didn't mention that. So to start with, we are dealing with a peripheral hypotonia, and it's either muscle or a myoneural junction or peripheral nerve, and it is acquired, and it is progressive, and the family is living in an area where there is which is still under construction. All these are clues to the case. What do you think the diagnosis is? So what is the lesion? Where is the lesion? What is the lesion? Where is the lesion? B for recovery, B for recovery. Why? Yes, this could be a good answer. Why? What is the lesion? Where is the lesion? I see botulism. Lead poisoning. Lead poisoning is not a bad idea, but usually it takes time, and usually does not present that early, unlike botulism. And what are the cardinal manifestations of lead poisoning in newborn and in infancy? Usually in infancy, there is anemia, there is GI problems in the form of colics and constipation, and there is peripheral neuropathy like foot drop. So it's a good thought, but it is not the case. And it doesn't fit into the diagnosis here. And it doesn't cause cranial nerve involvement as in this case. So we think this is most probably it is botulism. Okay, what is the classical presentation of botulism in the newborn baby? Usually it starts to present around the age of 3 weeks, the same as in this scenario. And it is characterized by severe constipation, progressive muscle weakness, progressive hypotonia. The baby is very floppy, and associated cranial nerve involvement, which fits into this case. The unusual eye movements, because the eye is supplied with cranial nerves, poor feeding, poor weak cry, significant head lag, meaning significant hypotonia. Most probably this is a case of botulism. What happens is that the intestine or the GI of the baby is colonized and then infected with the Clostridia. They secrete toxins, different types of toxins are available, and they start acting on the myoneural junction. And they stay there for some time. They take months till spontaneous recovery happens if the baby does not die. And till these toxins are neutralized. So the goal of the treatment is supportive treatment for a period of weeks till the baby has spontaneous recovery. So what they do intubation, assisted mechanical ventilation, TPN or gastrostomy feeding, and immediate administration of immunoglobulin against the botulism toxin. A very important question outside this scenario: what is the food that is most commonly responsible for botulism if given to the newborn baby? Because this is important. What is the food? Honey, yes, correct, yes. So please don't give honey before the age of 1 year. we'll go to this is how you manifest. One of the methods you test for hypotonia is head lag. And if there is massive head lag, there is massive or severe hypotonia, which is characteristic of peripheral hypotonia, mostly myoneural junction, as in this case. Infant botulism is considered in the differential diagnosis in any previously healthy neonate, the same as in this vignette, with abrupt and progressive symptoms, constipation. We didn't know about that in this case. Weakness, yes. Weak cry, yes. Cranial nerve dysfunction, yes. Human-derived antitoxin, this is the treatment. Botulism immune globulin should be administered in all suspected cases, even before you get the final results, because it might take some time, but this is going to save the life of this baby. All cases of infant, we don't care about that. Okay. So hypotonia, this is the differential diagnosis of hypotonia. It could be a sign of central nervous disorder like CP. It could be a primary neuromuscular disorder, as we are going to see in tables. It could be a genetic syndrome like Down syndrome, Prader-Willi syndrome. Also, it could be associated with congenital infection, sepsis, hypothyroidism, hypoglycemia, intracranial bleed, drug toxicity, and the most important drug that can cause that in a newborn is the magnesium. And why? Because it is used in the treatment of many maternal disorders, including eclampsia or to prevent preterm labor. And because it's usually given as a routine to improve the development of the brain of the newborn later on in life. So magnesium toxicity can cause that. It's more common than the lead poisoning. If these more common conditions can be excluded, genetic syndromes or a primary neuromuscular disorder should be considered. So if you can exclude all the above, you are most probably left with the neuromuscular disorder. Okay. So weakness and hypotonia in newborn can be caused by several conditions, including neuromuscular disorders of the myoneural junction, including what are the conditions affecting the myoneural junction in the newborn. This is another important differential. Once you reach the problem is what is the lesion? Where is the lesion? Myoneural junction. So you have to try to find out what is the lesion. It could be transient or some persistent kind of transient acquired neonatal myasthenia gravis. You have to keep this in the back of your mind, especially when you have abnormal eye movement. Congenital myasthenia, elevated levels of magnesium, as I mentioned. Aminoglycosides, be careful about that because we are extensively used in the newborn period. Aminoglycosides can cause, can affect myoneural junction conduction and cause weakness and hypotonia. This is extremely important differential. And comes infantile botulism if the history is suggested by honey, giving honey to the baby, or if there is massive constipation and the baby was healthy till the age of about 3 weeks, then starts to develop abrupt progressive weakness and hypotonia. So it could be transient or it could be permanent. And we talked about this and this. And this table shows some examples because the differential of hypotonia and weakness is massive. And you have to narrow the differential diagnosis. Otherwise, you will not be able to reach any diagnosis. It could be in the anterior horn cells. There is what they call congenital motor neuropathies. It could be muscular dystrophy. Of course, not all of these diseases occur in the newborn period. You have to select what presents early. And then you could have mineural junction disorders, and this is like the myasthenia. You can have metabolic disorders and the congenital myopathies. This case, this is our differential in this case now, because it is mineural junction disorder. It could be myasthenia, neonatal myasthenia, acquired, transient, congenital myasthenia, magnesium toxicity, aminoglycoside toxicity, infantile botulism. Okay, so progressive hypotonia in a previously healthy infant without fever, rash, other signs of infection has a broad differential diagnosis, including genetic disorders, neurologic disorders, metabolic syndromes. These infants will often undergo an extensive evaluation, including laboratory studies, brain magnetic resonance imaging, muscle biopsy before a final diagnosis can be reached. Universal newborn screening has allowed for the differentiation of certain, for the identification of certain inborn errors of metabolism and spinal muscular atrophy. These are part of the newborn screening in the States, in most of the states here. I don't know about Egypt. A medical history can be revealing. So starting from the history, in this vignette, where the family relocation to an area of new housing construction with soil disruption, where these Clostridia spores live in the soil. Soil disruption puts the infant at the risk for exposure to botulism spores. History combined with symptoms of progressive poor feeding, weak cry, unusual eye movements, significant head lag strongly suggested a diagnosis of infant botulism. Infants are particularly susceptible to neurotoxic manifestations of botulism because their immature intestine are perfect medium in which the live botulinum spores can replicate and produce toxins. Opinions vary about whether breastfeeding confers the protection to vulnerable. We don't know if breast milk protects against botulism or not. Toxic neutralization bioassay and mass, this is how to diagnose, and mass spectrometry analysis for Clostridium toxin are performed on the stools suspected of botulism, and the stool should be fresh. Okay. Once diagnosis is suspected, you have to start treatment immediately. Standard treatment is administration of human botulism immunoglobulin antitoxin, which is specific. We have type A, type B, and after administration, you can continue supportive treatment, respiratory-wise, feeding-wise, and usually the baby will recover depending on how bad was the situation. After a few weeks, and you still have a chance to give these immunoglobulins till the age of 6 months, because at this point the immune system is not mature enough. In addition, you should not use aminoglycosides, of course, and supportive care antitoxin should be make a complete recovery. So that's why answer B is the correct answer. And usually it takes from 15 days to 36 days, and it reduces mortality from 90% to 15%. Questions? And comment.
في two questions يا دكتور إيهاب في ال Q&A.
ممكن توضح الفرق بين
بالظبط
ايه؟
بين السنترال and the upper motor neural lesion And how to assess weakness in your neonates.
How to assess weakness when we can. I have lectures about newborn assessment, and part of this is neurological examination, and part of this is how to assess power. And it is simply try to antagonize the action the muscle is doing. For example, you need the baby to extend his elbow. So you try to stimulate the skin of the forearm, the frontal aspect. So the baby should extend the elbow to keep away from the stimulation. And you can do this with every and each muscle. This is how to test for the power, how to test for the power. Now, the other part of the question is difference between central and upper motor neuron lesion. Upper motor neuron lesion, the tone is high, is increased, and there is positive Babinski, and there is exaggerated reflexes. But in central hypotonia, no, the tone is low, and you may or may not get the Babinski, the positive Babinski, depending on where is the lesion. So it is not difficult to differentiate central from upper motor neuron lesion. Okay. Another, how to assess weakness. Yes, we answered that. Yes, any other questions? Any other questions? What is the effect of botulism during pregnancy on the coming fetus? Effect of botulism during pregnancy on the coming fetus? I don't know the answer of this question. You can ask our colleagues in labor and delivery. I don't know. I didn't think of this question, but I can check it for you and send you the answer, Dr. Ahmed. Somebody is saying preterm labor. I don't know, maybe, I don't know. So what else? No more questions?
لو سمحت يا دكتور، هو احنا قلنا ان هو exclusively breast feeding، ازاي بقى البوتيوليزم
Exclusively
وصلت للبيبي exclusive breast feed؟ يعني ازاي السبورز دخلت للنيونيت وهو 3 weeks؟ يعني ما فيش اي انترال او elemental root.
هو this is environmental. The family relocated into an area of reconstruction. So the environment is contaminated. The mother breast and skin is contaminated. And the GI of the baby got colonized, contaminated, colonized, and infected. It is not through the breast milk. It is through the contact with the mother and the family. She is cleaning the mouth with a cloth. She is giving her breast to the baby, which the skin is colonized and so forth.
Yes, thank you.
Yeah, the mother doesn't have botulism, doesn't have breast milk spores. It is through the environment. I hope this is clear.
Clear. ماشي، شكرا.
Okay, what else? Dr. Marwa, do you see cases of botulism in Egypt?
لا يا دكتور، بس أنا كنت سمعت جزئية كده في موضوع العسل، إن العسل اللي في مصر لسبب ما فيهوش بوتيولينم توكسينز.
عارفة
لكن
ليه؟
ليه بقى؟
عشان مضروب.
ممكن،
عشان عسل
لكن
مضروب. أنا لسه شايف من شهرين كده كان في هيصة على السوشيال ميديا. جماعة شباب متحمسين عملوا study عن الإيجيبشن هاني. All products, all brand names, all types, كلهم in the market كانت عسل مضروب. واخده بالك انت؟ and they feed the honey the bees on sugar which is not ethical. Okay, so this is from my point of view I think this is the cause.
تاني حاجة المشكلة إن برضو يمكن في المستشفيات، يمكن بعد المحاضرة بتاعت حضرتك دي أو الأسئلة دي ممكن الناس تحطها في الديفرنشال دايجنوزس بتاعها أكتر. لأن إحنا بنشوف حالات هايبوتونيا كتير. يمكن ما وفعلا في حالات منها بيحصل لها spontaneous recovery بعد كذا يوم. فأكيد بعد كده هو لازم تتحط يعني في ال differential diagnosis يعني.
Usually it takes more than كذا يوم يا دكتورة مروة because the toxins are at the myoneural junction and they need time to be neutralized or for spontaneous recovery. It needs weeks.
يعني about 2 weeks يعني، لأن أنا في حالات مرت عليا
Yes, ممكن
يعني
2 weeks
كان
if the infection
عندها
is mild.
تمام. في برضو جزئية تانية بما إن إحنا بلد زراعي يعني، إن برضو لازم نفكر برضو في الأورجانو فوسفورس بويزنينج، لأن برضو بيعمل cranial nerve affection، بيعمل hypotonia، بيعمل excessive secretion، وفي a lot of
أيوة.
case reports and case series.
There is a very prominent feature of organophosphorus poisoning which is ده اللي حضرتك قلت بالظبط excessive secretions and the baby will drown in his or her own secretions which is not the case with botulism.
بالظبط، بس مش كل الحالات. في a lot of case reports موجودة ومنشورة ما فيهاش حتى ال excessive secretion. الأطفال عندها hypotonia and plus or minus cranial nerve affection بس poor feeding حتى. يعني يعني التحليل بتاعها موجود عندنا في قسم التوكسيكولوجي، وكمان يعني
Did you see cases?
احنا ما دورناش، ما بدأناش ندور عليها، بس اللي لفتت نظري ليها قريب يعني حد من قسم التوكسيكولوجي بيحاول يعمل جايد لاينز للاورجانوفوسفورس بويزنينج في البيدياتريك، فلقيته مطلع كيس ريبورتس كتير في نيونيتس، فقعدنا ندور على الحالات دي.
The treatment is life saving. What is the treatment in addition to supportive treatment? What is the antidote?
اتروبين.
Yes, it could be life saving. Yes. I don't know, but this is based on your experience. This could be a very good option. This could be a very good differential you can add to the differential diagnosis we talked about. And if you have cases, and if you publish it, it will be very, very, very prominent publication. I encourage you to, if any baby is coming from Al Aryaf and is having hypotonia, poor weak cry, poor feeding, with other autonomic nervous system manifestations like excessive secretions, and you check for organophosphorus and you give giving atropine may not be that harmful if you weigh the benefits against the disadvantages. If you give it when you suspect the case, and it might give a good response and save the life of this baby. It's a very, very good case report or research point of research. Okay.
تمام يا دكتور، شكرا لحضرتك.
حد كاتب حالات المانيا. Yes, حالات المانيا proved to be poisoning. 6 siblings. 6 siblings died in mania, most probably because of poisoning. Most probably, yes. Okay. Can we move to the next question?
معلش يا دكتور، في سؤال في Q&A. Does all babies should receive botulism IG immunoglobulin?
Does all babies should receive botulism immune يعني ايه all babies؟
مش فاهم قصده اقول affected babies ولا all babies in general يعني.
مش عارف انا مش فاهم السؤال.
ممكن
دكتورة
تفتح المايك يا دكتور؟
دكتورة are you a can you explain what do you mean by does all babies? You mean it is contraindicated in some conditions? This is the
هي الدكتورة عملت كومنت ان هي تقصد البيشنت يعني.
the patients. I am sorry. Does all babies can all babies receive botulism immunoglobulins? You mean is there a contraindication? This is what you mean?
لا انا قصدي انه الاطفال اللي بتكون مصابه في البوتيوليزم وانا ادخلها النيكيو وتكون على فنتيليتر، يعني لازم المرضى دول اديهم البوتيوليزم اميونوجلوبولينز.
طبعا.
طب وفي حال مش موجود في البلد اللي انا موجوده فيها؟
يبقى you have to keep this baby on the ventilator for weeks.
يعني هما ممكن يعني يصير في جود هيلينج حتى لو ما اديتهمش البوتيوليزم اميونوجلوبولينز.
Yeah, at some point they will recover on their own, but you have to support their breathing and feeding. I don't know if you have the capabilities in Egypt to keep those babies alive for weeks on ventilation without having ventilation associated problems, without having problems with TPN infection. Yes, you can, but if you give it, you will accelerate the process of recovery and you will improve the as we said, the mortality and the morbidity.
تمام دكتور، شكرا جزيلا.
Can we give IVIG as a replacement? No. No, you have to give the specific antibodies and specific immunoglobulins, period. Okay? I have more questions and more cases that are very interesting. Can we proceed?
تمام يا دكتور اتفضل.
Question number 10, which needs you to focus. Okay? Yeah, this is a very important question and we discussed it before. So I believe all the colleagues in Chat B will know the answer immediately. But this is not an uncommon problem and you can face this problem in real life. And you should know how to diagnose, how to manage. A term infant, C-section, because macrosomia. Baby had initial hypoglycemia, received IV glucose on the second day after birth. The neonate said on day of life 2, there is apneic episode. This is important key word, apnea. Apnea in a term baby is something very serious. You have to take this very cautiously and you have to be very, very assertive in the diagnose and manage. Apneic episodes in a term baby is totally different from apnea in a preterm baby. Preterm babies can have lots of apneas, tons of apneas, no problem. But in a term baby, apneic episode is very concerning. The baby had brief period of cyanosis. Apnea, any apnea could be associated with cyanosis, but there could be other causes leading to cyanosis in this case. Baby required stimulation. Blood glucose was not low, so it is not hypoglycemia that causes the apnea. EEG demonstrates persistent spike wave discharge in the, so there was a focal on the left side. Abnormal EEG changes, which means that most probably the apnea was due to or was a kind of subtle seizure. So this baby developed apnea, most probably it was a seizure, subtle. They did two-dimensional echo. They found normal cardiac anatomy. The structure of the heart was normal, but there was enlargement of the right ventricle. There was right to left shunting across the patent ductus. Dilatation of the innominate vein and superior vena cava. What does this mean? When you have a baby with two-dimensional echocardiogram findings of enlargement of right ventricle in a normal heart structure-wise, with left-right shunting across the PDA and dilatation of the innominate vein and superior vena cava. What does this mean? What is the interpretation of the echo? No, it does not mean PPHN. Sorry, this is no. If there is PPHN, why the innominate and the superior vena cava veins are dilated?
Total anomalous.
It means high cardiac output. There is a missing word here. High cardiac output, what? Failure. High output cardiac failure. So, his term baby had apnea, which is most probably due to a subtle neonatal seizure, and has evidence of high cardiac output heart failure. So what is your differential and what is the diagnosis, which is easy now? What is your differential and what is your diagnosis? Right to left shunt. Yes, right to left shunt. Where? Yeah, there is a right to left shunt in intracranial because there is seizure. So this baby have some CNS problem. So it's a vein of Galen malformation. Bravo, Ali. Yes. And what other presentations the vein of Galen can present with? In addition to high cardiac output heart failure because of left to right shunting. And what else? Or what are complications? It has different presentations because of and because of problems also or complications. AF pulsation, يعني anterior fontanelle pulsation, no, I don't think this is correct. But the anterior fontanelle could be bulging because it can cause a mass effect, increased intracranial tension, hydrocephalus. Bravo, Alec. Yes, can present with hydrocephalus. It can present with intracranial bleed. Yeah. Yes. Ischemia. Yes, all these are possible. And there you can, if you auscultate the head, you can hear what is the sound you can hear. When you auscultate, I see murmur. It is not called murmur. It's called bruit, which is an abnormal sound on auscultating the head. So, of the following, the test result most likely to be found in this infant is A, CSF culture growing HSV, herpes, CT of the head showing subdural hematoma. What causes subdural hematoma in the newborn infant? And this is the most common type of intracranial bleed in the newborn, is the subdural hematoma. Usually it is because of birth injury. And how it presents, it's either asymptomatic or increased intracranial tension or pressure on the brain, which might be mild, moderate, or severe, from just neurologic deficit lateralization up to compression of the brain stem and a herniation of the brain, which is something very serious. Can the vein of Galen present with subdural hematoma based on the CT? Cranial ultrasound demonstrating mild ventriculomegaly. Cranial ultrasound is a very good tool in the diagnosis of vein of Galen, but in this case, does it is possibility of mild ventriculomegaly? I don't know. Magnetic MRI of the brain suggesting AV malformation. So which is the correct answer? A, B, C, D, and why? D, 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 yes. D is the correct answer. Let us see why. But before we go to why, we'll give you some few hints about the vein of Galen. It's a midline structure that together with the inferior sagittal sinus drains blood to form the straight sinus. Some people call it aneurysm, but it is not a true aneurysm, because there is one or more arteriovenous shunt that shunt blood from the arterial side coming from the carotid and vertebrobasilar system in the midbrain to the vein of Galen. So there is shunting of blood from the arterial side coming from carotid system or vertebrobasilar system to the vein. So it's an AV malformation. And when there is blood coming from the arterial side to the venous side, the vein will become distended, enlarged, and here comes the problems. Number one is left to right shunt, high cardiac output, heart failure, compression of the ventricular system and hydrocephalus, mass effect on the surrounding brain structure, rupture, intracranial hemorrhage, infection, and it could be one arteriovenous or more, same as in this picture. So high flow blood into the vein of Galen causes it to dilate. The high rate of blood flow is also transmitted to the heart to cause high cardiac output, heart failure. Estimated incidence is 1 per 10,000 up to 25,000 births. It accounts for 1% of all congenital anomalies. And the sonography is, whether fetal or neonatal, ultrasound is extremely important tool of diagnosis, especially the color Doppler, as we see in this case. This is fetal. And then this baby might present with a high cardiac output, heart failure. And the prognosis in these cases depends on whether there is high cardiac output, heart failure, and the degree. The prognosis depends on the severity, time of presentation of the cardiovascular symptomatology. So in any baby who has high cardiac output, heart failure, as if he has a very large ductus, and you check for the ductus and you find it either there is no left to right shunt or it is right to left shunt, you have to think of AV malformation somewhere else. And one of those is the vein of Galen malformation. So seizures, oh yes, this baby had subtle seizures because the apnea was due to subtle seizure. And I said apnea in a term baby is something very serious. Seizures in the newborn and infant may manifest as apneic episodes. Newborn and infants with cerebrovascular arteriovenous malformation may exercise seizures. This is one of the presentations also. Because it causes ischemia of the surrounding brain structures, it could cause pressure, could rupture in blood leak in the surrounding area. All these cause irritation and seizures. In preterm babies, apnea, we know about apnea in the preterm babies, but as the baby becomes more mature, apnea is very, very unusual in the term baby, occurring only in 1 per 1,000 term babies. So if you have a term baby with apnea, you have to evaluate carefully and look for why this baby had this apnea. And then, because apnea could be a sign of seizure, you have to do an EEG. Okay? And as we know, 50% of seizures in the newborn are subtle, and they can manifest as lip smacking, blinking, stirring, apnea, abnormal eye movements, bicycling, protrusion of the tongue, periodic decreased responsiveness, sudden arousal, and apnea. And subtle seizures may be difficult to identify and thus frequently overlooked because of the absence of jerky movements. The underlying cause of subtle seizure includes, in addition to the brain issues that we discussed, metabolic derangement like hypoglycemia. At the time of the seizure for this baby, there was no hypoglycemia. Initially he had, but he didn't see it. When he had the apnea, the sugar was 65. Hypocalcemia, sepsis, central nervous system infections, including meningitis, encephalitis, arrhythmia, cardiomyopathies, respiratory infections, neurological pathology, intracranial hemorrhage, congenital brain malformation. Okay? And the EEG can help you. And if the abnormality in the EEG is focal, you think of focal lesion. If it is generalized, if you think of generalized lesion. And although sharp wave discharges, as in this baby, can transiently occur in healthy newborn, the persistence of these waves in isolated area may indicate epileptiform discharge. Isolated focal sharp waves may be indicative of focal injury, in contrast to multifocal sharp waves, which are commonly seen in diffuse brain injury. So, dilation of the innominative vein associated with high output cardiac ventricular failure. This suggests this baby is having seizure because of neurovascular pathology, so arteriovenous malformation. Physical exam in baby with cerebral arteriovenous malformation may include cranial bruit and evidence of congestive heart failure. Cranial ultrasonography is a good diagnostic tool, and it will help you to show the vein of Galen as a midline echogenicity, and you can check it also with the echo Doppler. And also MRI can give you that more accurate diagnosis. Okay, and the treatment is surgical based on how when you do the surgery, based on how the baby is hemodynamically stable. This is not a subdural hemorrhage, which is the most common intracranial bleed in the newborn. Infants with subdural hemorrhage may be asymptomatic. They may have apnea, seizures, and or respiratory depression. And most commonly occurs at birth because there is birth injury during vaginal or instrumental delivery. And associated EEG changes may vary from suppression of alpha wave to irregular, slow. So the EEG pattern is different. And of course, the presentation clinically is different, and it does not cause heart failure. The same with the herpes, which usually occurs between day 7 and day 25. There is fever. Fever is a prominent feature in HSV infection, systemic. There is lethargy, seizures, respiratory depression, can affect all the body, but it doesn't cause heart failure. Okay? Newborn with mild ventriculomegaly are typically asymptomatic. So this baby, if his problem was only mild ventriculomegaly, he will not present with seizures or with the high cardiac output heart failure. Questions or comments? Q and please, we need the link of your lectures of neonatal examination. I didn't start those lectures yet. Dr. Marwa, I have a very, very good educational, I told you about that, series about, it is back to basics, starting with assessment of the newborn infant. And it includes history, maternal history, immediate neonatal history, Apgar scoring, assessment of gestational age, and then general assessment of the newborn infant. How you do examination of the heart, of the abdomen, of the nervous system, of the skin, etc. And the examination of the preterm infant, examination of the syndromic infant. It's a very, very good lecture series, and whenever you're ready, I can start it. I have it ready already as PowerPoint. It's very, very educational, and especially very good for juniors, for junior staff, and even for senior staff. It will confirm their knowledge, correct some of their knowledge, and add to their knowledge. I think so. So, okay. Why shunting blood from arterial side to venous side is considered left to right shunt? Shunting is either right to left or left to right. The arteries are connected to the left side of the heart, so it is left, and the veins are connected to the right side of the heart, so it is left to right. The same as ductus arteriosus. Usually it is left to right, unless there is another problem, as in this baby. So this is left to right. This is easy. If it is the other way around, from the venous side to the arterial side, it is right to left. As we saw in this baby, across the ductus. So this baby, maybe what is confusing is that this baby has two shunts. The vein of Galen is left to right shunt. But at the level of the ductus arteriosus, it was right to left. And that's why this baby developed some cyanosis, either because of this or because of the apnea. Okay. Please, we need the link. Oh, I talked about that. I didn't start it yet. How to differentiate between normal movement and subtle? No, this is a big. This is a big issue, and we did a very, very good lecture about neonatal seizures, and we don't mind repeating it again and recording. And unfortunately, it was not recorded, but we can talk about that, or we can redo this lecture again and record it. Okay. If suspected antenatally, any special precautions in resuscitation? If it's suspected antenatally and there is an evidence of fetal high cardiac output heart failure, it should be treated in utero. Otherwise, this baby might develop hydrops. Okay? But if there is no cardiovascular compromise, then resuscitation will be the same as other babies. Can we start the series next time? No. I'm sorry. This decision is based on a lot of issues, and we discussed with Dr. Marwa, Dr. Ahmed, Dr. Manal, Dr. Ebrahim. We have many other issues, and we have many other lectures ready to present. So once we done with our schedule, I promise you, I will present these lectures, and it will take maybe around 1 month or even more. If I give it once weekly, if I give it twice weekly, might do it faster. So I cannot promise you I'm going to do next time. I'm sorry. The decision is multifactorial here. It's not in my hands only. Some radiologists refuse any radiology study in newborn bearing radiation dose, and this is a very weird. This is very weird radiology policy. In the newborn babies, like any other human being, we do all types of radiology. When indicated, we don't do it for fun. We do it to diagnose something that we cannot diagnose clinically. And we do X-ray, conventional X-ray, we do CT, we do ultrasound, we do MRI, we do, this is not, I'm sorry, if the radiologist refuses, go to another one. Ask another radiologist. This is not fair, and this is not a good policy, and I don't know who invented this. Most of cases we cannot diagnose in neonatal period because lack of investigations, tool, and lack doctor experience in this neonatal period. So the correction of this by more education, more learning, attend more neonatal lectures, be with us every Saturday, and you will build up your experience and your knowledge. And once we discuss something, you have to go and read about it. Otherwise, it will disappear in few days. أيوة دكتورة مروة اتفضلي.
دكتور بالنسبة للإيفي مالفورميشن أو الفين اوف جالن هي موجودة الصراحة، يعني احنا بنشوف حوالي من 3 ل4 حالات في السنة. في منهم بيبقى يعني مثلا من 4 حالات بيبقوا 2 diagnosed antenatally، فيمكن هم الدكاترة اللي ما بيشوفوهوش يعني يمكن عشان مش موجودين في tertiary center. دي أول حاجة. تاني حاجة في حالات احنا بنكتشفها بالصدفة بالكرينيال التراساوند، ومعظم الوحدات دلوقتي في الجمهورية كلها اعتقد فيها اكسس للسونار، يعني حتى ممكن المستشفى نفسها تستأذنه بتاع الأشعة وتطلعوا السونار وتبصوا بالكرينيال التراساوند كده ايه كل يومين في الأسبوع ولا حاجة على كل الحالات اللي موجودة في الوحدة. اعتقد هتشوفوا او هتكتشفوا حاجات كتير. فالدكاترة اللي بيقولوا
There is a very good lecture that we are going to present in the future, which is use of ultrasound in the NICU. It is very, very good lecture, should be up to date. And now ultrasound is a very good, sensitive, dependable tool of diagnosis in the newborn, in the newborn patients and in the NICU. Not conclusive because lack of radiologist experience. What is the not conclusive? What is the not conclusive? The lack of experience is not an excuse, and the chance for education and learning is now much easier for everyone, each one interest. If you need to learn something, you will learn it. So it's, I mean, in my point of view, it is lack of time. Everybody is is running behind أكل العيش, and they don't read, they don't train, they don't get new education, they are not up to date. And this is their problem. And now when we know that somebody is experienced in something, all the referrer will go to him, everybody will trust him, and the others will lose confidence. So lack of experience is not an excuse for radiologists. What is the prognosis of, it depends on if there is cardiovascular manifestations or not, how big is the abnormality, when it was diagnosed in utero or postnatally, and the chances of treatment. And this depends on experienced neurosurgery. And this is, I cannot judge this in Alexandria, but I hope they are doing a very good job with that. In general, public hospital, no experience. In general, and public hospital, no experience. I don't know, but now you have everybody has the chance to educate and teach himself. Can go to the YouTube, go to Google. You have tons of references online. You have tons of lectures online. You are very lucky. Your chance of education is much, much, much better than many generations ago. There is no excuse for lack of knowledge or lack of experience. Okay. May we proceed to the third MCQ, please? Because today we have a very busy day. Can we? Okay. No, we need 12. 12. Okay. This is a very good question. And it is common, by the way. A 5-day-old, so 5-day-old, 35-week, there was a spontaneous preterm labor. And there is a lot of difference between induced preterm labor and spontaneous preterm labor, which is most probably due to infection, maternal infection. Experience sudden onset of apneic spells. Okay. So this is a 35-weeker. So apnea is a very common presentation, but it is associated with lethargy. This is very concerning. So the keywords: 5-day-old, 35-weeker, apneic spells, lethargy. So what comes first to your mind? 5-day-old, 35-weeker, apnea, lethargy, infection, sepsis. But it could be some other issues. Blood and cerebrospinal fluid culture are obtained, what we should do if you have this baby. You should send immediate CBC and DEF, blood culture, urine culture, CSF for gram stain and culture, and the culture includes viral PCR. They started broad spectrum antibiotics, yes, Ampangent, and acyclovir, maybe HSV. In HSV is very common here, but in Egypt, I don't know, the situation might be totally different. Laboratory studies demonstrate moderate thrombocytopenia. So there is bone marrow affection, elevated hepatic enzymes. So there is hepatitis or coagulopathy. Sorry, I jump. Elevated hepatic enzyme, meaning hepatitis. CSF fluid shows lymphocyte predominance. There is pleocytosis, so there is something wrong in the CSF. Meningitis, encephalitis, meningoencephalitis. There is something. So this is 5-day-old, 35-week, presenting with apnea, lethargy, has evidence of bone marrow infection, hepatitis, meningoencephalitis, or encephalitis. Within 22 hours of clinical presentation, the newborn develops hypotension. So the baby starts to become hypotensive, shocky, and with tachycardia. So the heart is affected. An echo demonstrates decreased cardiac output. Decreased cardiac output means heart failure. And in this case, thinking in the scenario or in this vignette in the scope of infection could be myocarditis. The mother had a mild respiratory illness. This is a very important keyword. Mother had a mild respiratory illness around the time of the neonate's birth, maybe a few days before, few hours after, but around the time of delivery, mother was sick, had mild respiratory illness, most probably viral. Of the following, infection in the neonate is most likely caused by 5-day-old, 35-week apnea and lethargy, evidence of affection of the bone marrow, hepatitis, meningitis, meningoencephalitis, and maybe myocarditis also, and heart failure. What is your differential? What is your differential? Enterovirus, Coxsackie virus, enterovirus causes myocarditis, viral infection, early onset sepsis. Okay, why it's early onset sepsis? Are you why it's early onset sepsis? Only in universities, hospital, investigation can be done, so the problems are huge. So at least you can refer your sick babies to those hospitals, and then you can follow them up, and by this way you can get educated. C, viral infection, enterovirus, Coxsackie, enterovirus. What are the enteroviruses? What comes under this family, enteroviral infection? What are the important viruses that we know cause infection in the pediatric age and even in the newborn period? Enteroviral infections, like what? Coxsackie, polio. It is not pico. It is not pico, it is echo. ECHO. Yeah, it is not pico. Yeah, it's the poliovirus is echovirus, Coxsackie virus, yes. So what do you think is going on? Is it A, B, C, and D? You think, all of you think it's A. So why it's not B or C or D? Why it's not B or C? Not bacterial. Why? Lymph. Okay, what else? GBS, more aggressive. What is GBS? Oh, group B strep. Oh, okay. GBS is more aggressive. Lymphocytes in CSF, viral lymphocytes. No, but we in the vignette, we have more important points than the lymphocytes, which favors viral infection, which favors, because respiratory syncytial virus is a viral infection. Why you didn't choose D? Why it's not D? And why it's viral, not bacterial? Okay, let us move to the diagnose and critique. RSV may not cause sepsis. Myocarditis, mother history, yes. The history in the mother is very, very suggestive, yes. Myocarditis, yes, good. This is a good point. RSV usually causes upper or lower respiratory infection based on how preterm is the baby, and it could be very serious, could be mild. So it's not RSV. GPS and listeria, they don't cause all these combinations, including myocarditis. So, enteroviral infection can be life-threatening in the early neonatal period, mortality rate up to 30%. Hepatitis, myocarditis, meningoencephalitis. So these combinations make you think of enteroviral infection, especially the Coxsackie one. Hepatitis, myocarditis, meningoencephalitis are the most common serious complications of neonatal enteroviral infection. The neonate in the vignette has been evaluated for sepsis, the history of maternal respiratory illness just before delivery. This is a very important key point. Combination with the neonate's clinical findings, hepatitis, myocarditis, meningitis. This combination make you think of enteroviral infection. So enteroviral infections are classified in the ECHO, and the ECHO, the ECHO comes from enteric cytopathic human orphan virus. And it has some serotypes, Coxsackie A and B, which is one causing myocarditis, A or B? A or B? A or B? No answer. B. Usually it's B. And there is some serotypes. Polio, yeah, but usually polio, we don't see polio in this age and in this presentation. Totally different story. Other newly diagnosed serotype. Non-polio enteroviral infections are more common in the newborn. Enteroviral infections, which most typically occur in the summer and autumn. This is in USA. I don't know about Egypt. And they give you a sepsis-like picture, but the combination of hepatitis, myocarditis, meningitis is very suggestive of enteroviral infection. Are most commonly transmitted via fecal oral route or respiratory route, droplets, inhalation. Infections in the newborn also may be acquired vertically before delivery through the placenta, or during or after delivery during passage in the birth canal, which is more common. Intrapartum contact with infected maternal blood, amniotic fluid, or other fluid. So many routes of infection is the most common route. Okay, intrapartum contact with infected maternal blood or amniotic fluid or other body fluids is the most common route for infection. Transmission via breast milk is possible again, and horizontal transmission may occur if after birth, if there is family member infected, or staff in the NICU or on the well baby nurse. Prematurity is a very risk factor for increased neonatal morbidity and mortality. And as in is perinatal acquisition or infection in the first week after birth. Early infection is also associated with high mortality. Mortality rate up to 30% can happen. Common clinical findings include temperature instability, rash, Rash is very common with enterovirus, as we see in older babies, the hand, foot, and mouth syndrome and this problem, but not in the newborn. Poor feeding, respiratory symptoms. The most common complication associated with severe enterovirus is hepatitis. So this is a very common presentation. Associated coagulopathy, 46%. Clinical manifestations related to hepatitis may include jaundice, ascites, hepatosplenomegaly, and thrombocytopenia. So the thrombocytopenia is either because of the splenomegaly, eating the platelets, or because of the bone marrow, or because of the liver disease. Hepatitis may progress to liver failure and even hepatic necrosis and fibrosis. It's something very serious. And the peak serum ALT and AST correlate with the outcome. So the higher the ALT and AST, the lower the worse the prognosis. And if it's more than 1,000 unit, it's associated with a higher case fatality. So you have to check liver functions, and this will help you in the diagnosis and in the prognosis. Myocarditis is also common, and it's a sign of severe enteroviral infection. Associated mortality is high. Myocarditis can present with respiratory distress, apnea, arrhythmia, heart failure. It may be evident by clinical findings of elevated troponin, type B atrial natriuretic peptide, ST segment changes on the AKG, and ventricular dilation or the decreased systolic function on the echo. Meningoencephalitis also in 11%. They may manifest with lethargy, irritability, hypotonia, seizures. Magnetic resonance imaging demonstrates white matter chain. So the diagnosis can be confirmed by a blood or body fluid enteroviral PCR. I don't know if you have this test available in Egypt or not, but you can, we used to do what they call viral panel. And they can take a sample either from the nasopharynx, but it can be taken also from the blood or any body fluid. And they do PCR, and the results does not take much time. Treatment of enteroviral sepsis includes supportive care, giving blood products like platelets if the platelets keeps dropping. In severe cases, IG might be helpful. Antiviral drugs still not available in all countries, and they use what they call the capsid binding inhibitor. And the one that is used now is called R856932. And this is available in Europe, but not in USA. Okay, then comes to although neonatal infection resulting from GPS and listeria may be seen in the first week after birth, association of maternal respiratory illness just before the birth of the neonate in the vignette raises concern for viral infection. If the mom is having, usually GPS in the mom is just colonization and listeria also. But this history of respiratory illness in the mom is in favor of viral infection in combination with hepatitis, myocarditis, meningitis, which does not happen with GPS and listeria. And with RSV, it is usually respiratory problem only, mostly upper or lower. The more the baby is preterm, the worse the presentation and the worse the complications. And I know now that you have the synergies available in Egypt now, which is good. Now we go to questions and comments. So may this case FT apnea approach your English is مجعلص خالص يا جماعة. I don't get it. May this case FT apnea approach. What is the question? على رأي القذافي. What was the question? FT apnea approach. أنا مش عارف يعني إيه الحقيقة. Any other questions? Okay, back to chats. Full term. Full term. يعني إيه full term? Full term. Where the full term? FF full term. مش عارف يعني إيه. Any comment or questions? We still have 30 minutes. We can present a case. Unless this is a very heavy dose, I can stop here. Dr. Marwa, Dr. Ahmed, Dr. Akram, what do you think? Dr. Abdul Rahman, Manal, all other guests, what do you think? Stop here? It's up
لا
to
يا
you.
دكتور لا يا دكتور إيهاب، لا. ممكن
كمل
حضرتك
يا
تواصل.
دكتور.
I have many interesting cases. It's
محاضرة جميلة جدا يا دكتور. كمل بس.
والله يا حبيبي, thank you very much. So, screening sharing has stopped as the shared window is closed. Okay, I will share screen again and go to another. Okay, share. طيب يا عم أنا مش عايز دي خالص, أنا مش عايز دي. أوكي, أنا هروح لواحدة تانية. مش عايزك انت خالص. Case. Now, do you see my screen now?
أيوة يا دكتور.
Okay. And then we'll go to the target case, which is case number 12.
في
no,
سؤال يا دكتور عن الكيس اللي فاتت بيقول could corona cause this case?
Was what?
Cause the
corona
previous
cause what?
presentation.
Cause
Cause the previous
coronavirus?
presentation. Yes.
To be honest with you, Bardo, I don't have much experience with the corona, to be honest with you. Lakin, I believe, yes, the answer is yes. The answer is yes. But this MCQ is very recent. It's very recent. So I don't know why they didn't include the corona. I don't know. Maybe it's not that common. Maybe the corona now has a different attitude and different, but yes, the answer is yes. Case 12. Okay. This case is very difficult, but it is very important in the differential diagnosis. It is extremely important in the differential diagnosis. So that's why it's important. And also it refers to a very interventions that I don't know you are familiar with or not. So let us start. Female, 24-weeker, maybe up or down 5 days. Mom is G3 para 1, 30 years old, delivered via C-section because of breech. Okay. Mother received antenatal steroids, had type 2 diabetes. Birth weight is 581 grams, which was a 22.5 percentile. And also this was a proportionate baby. Head circumference and length were appropriate for age. Infant was intubated at delivery and receives surfactant, 1 dose. And then they started high frequency oscillator. This is the guidelines and their NICU. You don't have to do that in your NICU, but this is what they do. Initial chest radiogram, this is important, showed our classical RDS. They didn't do ultrasound. And I don't know, it is still not standard of care in many NICUs. But from my knowledge, you use it in CHADP and it is very, very, very helpful. But many of the scenarios, I don't see ultrasound at all in the initial assessment of respiratory problems in the newborn. I don't know why. But they did an X-ray, showed classical RDS. Okay? The problem started here. They started to go up and up on the FiO2 up to 85%. And then they had to give a second dose of surfactant at the day of life 4. I never done this before. Usually, as far as I know, the window for the surfactant is usually 48 hours. And I believe that if it doesn't work initially in this window, it will not work later. But this is what they did. They had to give another dose at the age of 4 days. And then they switched from the high frequency oscillator to the high frequency jet ventilator. So they like the high frequency. And then give a third dose of surfactant at the age of 9 days. Maybe because they don't have any other options. So they are trying to use all possible interventions. So they gave surfactant the first day of life 4, day of life 9, because the baby was not responding, was getting worse and worse. They had to change ventilation from high frequency to from high frequency oscillation to high frequency rejet. And however, still giving 100%, the baby is getting worse, 100% FiO2. Here starts the problem to show itself a little better. And the oxygenation still challenging. They did another chest X-ray. And this is the answer for the nice colleague who said that radiologists don't do X-ray because to newborn babies, because this is an overexposure to radiation. This is hocus pocus. They did another X-ray and they found multi-cyst. This is we starting to get more and more focused in the diagnosis and in intervention. Multiple cystic lucency. Multiple cystic lucency in the right lower lobe. So one side only was affected. One side only is affected. It's not both sides. With focal hyperinflation, there is a focal area that is more hyperinflated, meaning like a large cyst and multiple cystic lucency. And this was associated with mass effect, meaning the mediastinum was shifted to the left. And the rest of the right lung was collapsed. So there was a right upper lung collapse and mediastinal shift. They have to give intravenous steroids on day of life 12. However, because of the high oxygen requirements. And because they saw this lucency and baby started to develop pneumomediastinum, they had to go down on the settings of the high frequency jet ventilation. So at this point, if you were working in this unit, have a preterm infant who is having RDS on the vent from the get-go, multiple doses of surfactant not working, steroids at day of life 12, having a problem on the right side of the lung, a multiple cystic lucency with focal hyperinflation, compressing the rest of the right lung and pushing the mediastinum to the left lung and started to develop pneumomediastinum. What is your differential at this point? CPAM, yes, it's a very good idea. Need CT, this is not a differential. CCM, I say it's called CPAM now. PIE, yes. I hope you are not using Google or AI. Please don't do that. Either PIE or CPAM. Okay, for those who are thinking PIE, why it's not, it's only on the right side? Can we see PIE only in one lung? Yes or no? And why? Congenital diaphragmatic hernia, yes. Congenital lobar emphysema, yes. Yes, it could be all of the above. We still have other differential diagnoses, but the first two is PIE and CPAM, and their working diagnosis was CPAM. PIE can occur on one side, yes, and this happens if the tube is not in the trachea, if it's more or less towards one of the bronchi, mostly the right main bronchus, and in this way that the ventilation is different, the doses of surfactant are going more to one side rather than the other, so it could be PIE, cystic PIE. But still CPAM is on top of the list, and this comes second. And then what are other differential? There is still other problems that could present this way. Okay, you don't have the answer now. Okay, emphysema. احنا قلنا emphysema, congenital lobar emphysema, PIE. Cystic BPD, yes, it's a good diagnosis, yes. Although usually we don't call it BPD unless the baby is usually more than 4 weeks of age. Okay, they did some adjustment to the high frequency jet ventilation, oxygenation, still suboptimal, worsening, the cystic changes are worsening. And now we see an emphysematous plebs, meaning larger in size. They did antibiotic treatment, possible pneumonia. It could be pneumonia, repositioning, sedation, paralysis without sustained improvement. Then they had to do left main stem intubation, something which is very, very tedious. And I think they do it by laparoscopy. I don't know how. You can do right main stem intubation easily. If you keep going and pushing the ET tube, it will go directly to the right main bronchus. But to push it to the left, I believe you have to do bronchoscopy. But they didn't mention how. However, the baby did not tolerate this procedure at all, and they have to retract the tube. Okay? And then they started to do general surgery. This is what their last option. So this is the X-ray at the age of 27 days, and it shows you, this is when they did the left main bronchus intubation. And you see multiple multicystic lesions with focal, and then start to have blebs, and there is shift of the mediastinum and collapse of the right upper lobe of the right lobe of the upper lobe of the right lung. So this is their differential. They mentioned all the differential, which may or may not fit in this case, but this is the But it's important because it is the differential diagnosis of cystic lung lesions in a preterm infant. Cystic pulmonary interstitial emphysema, cystic PIE, secondary to ventilation associated lung injury, yes. CPAM, yes. Congenital lobar emphysema, yes. But usually it is on the left side, but never mind. And then other important differential diagnosis, necrotizing pneumonia. Necrotizing pneumonia, pneumatoceles, congenital diaphragmatic hernia, usually on the left side, but it can occur on the right or in the midline. Cystic BPD, yes. Usually does not start that early, but maybe it started early. So what happened to this baby? Became critically ill, hypotensive, because mediastinal compression, the heart also is affected, the cardiac output is affected. And so the baby was very sick. They had to do CT, and the CT confirmed there is a large lower lobe multicystic lesion, and they diagnosed it CPAM type 1. We gave a lecture, a whole lecture about congenital malformation of the lung and about CPAM, and we didn't record, so we might repeat it again and record. It was a very good lecture. And then at the age of 30 weeks, they decided to do surgery. What they did is, and the baby at this time was 1,300 grams, was thriving very well. They did right. And you see how they did manage nutrition of this baby very, very well. Baby was 500 grammer, was very sick. And at the age of 5 months was 1,300 grams. They did very good job with the nutrition. And then they did right lower lobe lobectomy. And they sent the sample for pathology. The baby had traumatic improvement. And they could tolerate, could wean the vent, they could extubate the baby. The baby was sent home. This is the CT confirming. And you see, this is the X-ray after lobectomy of the right lower lobe. Everything corrected. Both lungs look much better. Baby is in room air, went home, and I'm not going to go into more details, but this case was very educational, was very illustrative. A very sick preterm infant that received great care. And the surprise is the pathology result came PIE and not CPAP. Came in PIE, cystic PIE. And the management was great. And I don't know who is the brave anesthesiologist who put this baby to anesthesia, and who is the brave cardiothoracic surgeon who did lobectomy to this baby, but they saved the life of this baby. And how you manage PIE is a complication of ventilation of a newborn preterm with RDS, and usually it is not that bad, it's not that severe, and you have to wean the vent settings, especially the pressures, and this is going to help healing of the lung. And they did single lung ventilation, did not help. They did antibiotics, they did all they can do, and the surgical treatment was the solution. Okay. Before I stop at this point, I need to see what are your comments, questions. Surfactant deficiency, yes, this is a very, very good thought. But usually it will present as RDS that is refractory to treatment. But this baby problem was not this problem. It was the hyperlucency and multicystic lesions of the lung. Okay, so this is not that. Surfactant deficiency can cause refractory respiratory failure, yes. And it will not respond to any treatment, even surgery, whatever. And the baby usually die. It's not called surfactant deficiency. It's called surfactant protein deficiency, because surfactant deficiency happens in RDS. So surfactant protein deficiency, and the most common is protein B. And there is other abnormalities in the metabolism and synthesis of surfactant. This is another topic. Encysted pneumothorax. No. The X-ray picture will become totally different. And I don't think they can miss pneumothorax by like a regular X-ray. What about the CT? And no, it is not. Congenital lobar emphysema, it is in the differential diagnosis. Yes, it could be, but usually it is not multicystic. Usually it's more on the left, but it is in the differential diagnosis. Jazakumullah khair. This is not in the differential diagnosis. But thank you very much. Before we stop here, which we are 10 minutes less than 2 hours. Any comment, any feedback? Do you want to change this, the way we are presenting? Because 1 week I talk, 1 week our colleagues in Shabbi talk. And next talk will be fluid and electrolyte management in the newborn infant. It's extremely important topic. And no neonatologist, no one working in the NICU or even dealing with the normal baby nursery babies should not know how to manage fluids in the newborn infant. And it is should be based on scientific information. You should know why you're doing that, why you're doing how much fluids, and on day so and so. And this preterm baby, why his fluid requirements are different from the term, and so forth. It is extremely important. And I advise you all to attend and ask all your friends and colleagues to attend, inshallah, next Saturday. I will stop here. Dr. Marwa, do we have any comment or additions?
دكتور إيهاب، ممكن حضرتك تبعت لنا الفورماتات بتاعت الكيس بيز ديسكشن ولا صح؟
حضرتك من فضلك علي صوتك.
بقول لحضرتك ممكن تبعت لنا الباوربوينت بتاعت الكيس بيز ديسكشن ولا؟
Yes. Once I'm done, yes, this is what I usually do. Once I'm done with any topic or presentation or MCQ, I send the original article to you. But I cannot send it now because we still have some more MCQs and cases to discuss. Once I'm done, I will send it to you, and I will post it on WhatsApp on the E.U.P website.
إن شاء الله يا دكتور. شكرا جزيلا. شكرا جزيلا لحضرتك يا دكتور.
Thank you very much. Inshallah, we meet
شكرا
next Saturday, and I hope it's helpful. It's educational. It helps you in your career. And if you need any advice about your career as a neonatologist, I'll be more than willing to give you any advice, even on personal basis. If you can email me or send me any comments on the messenger on the Facebook, I will be very happy to help. Okay, thank you very much, and inshallah we meet next Saturday بإذن الله. السلام عليكم.
وعليكم السلام. شكرا جزيلا يا دكتور.
مع السلامة.
مع السلامة.